being able to manage change control. We have a broad array of new agents, and we are in a learning mode, having shifted from decades of using more traditional agents such as the Coumadin warfarin reagents and or the heparin reagents. We're in a whole new landscape now. While there has been data to show the effectiveness of the agents, one troubling concern is that a number of the agents also have some increased risk for bleeding. But in the trial designs, there really was no real focus on being able to manage complications associated with bleeding and needing to take patients to surgery. There are two classes of reagents, of course, the anti-coagulants and then the anti-platelet agents. I think one of the important things is for anyone that's dealing with these problems to know the mechanism of action, because that will tell you how best to monitor. The hemoclot test, and that test has a pretty good linear response to drug effect. But if one wants to look at drug effect, one could also use a PTT reagent as a rough gauge of efficacy. What people are evolving towards now is either use of APTT as a crude measure or using the hemoclot as a measure that actually has a fairly good linear response. Labs can acquire calibrators, so you can actually develop a curve that's a rivaroxaban-specific curve or an apixaban-specific curve. That takes work and that takes some investigation, and in point of fact, many labs right now aren't actually well set up to do that, but that's something that we need to think about. We, for years now, have used platelet count as the way to assess platelet-related bleeding, but we know that really what's important is platelet function. What we have in our particular facility is we use platelet aggregation test, and that's kind of unusual to have light transmission mediated platelet aggregometry 24/7. We're just kind of fortunate and have that. There are assays that can be used that are clinically applicable and could be launched in a number of labs. And these include tests like the Verify Now assay, which is it's not the perfect test, it's not the gold standard, but in the absence of another test, I think it's something to consider. Platelet Works is something to look at. It's a relatively easy to perform assay that looks at basically how many platelets you aggregate in the presence or the absence of the drug. And so anyone can use this pretty much on a Coulter-based platelet counting system. Is that we need an assay, and we need an assay that's available in most laboratories, and that's an area where I think that we need to continue to improve our clinical development. There was a nice in vitro study done by the group out of Emory where they mixed normal platelets in vitro with clopidogrel-treated platelets. And what they found was rather interesting. Anywhere from 2 to 3 platelet doses, and this is in a situation where one's fully inhibited, but anywhere from 2 to 3 platelet doses pretty much corrected the inhibition. So the story of needing 8 platelet doses to reverse Plavix and or Effiant is something that people need to really understand is an overshot.